are from Wharton. Oh, wow. Okay. How about from the engineering school? All right. Okay. And medicine? Wow. Okay. And who among us are not in school? Okay, that's great too. And welcome also to those who are joining us via the web. So this is being live streamed, so we would ask you to, if you have to leave pretty quietly, please. And Lucy, my co-founder, will tell us a bit about our educational initiatives that's going on, and then we'll jump right into the panel.
Yeah, thank you again, everyone, for coming out. Even this location is interdisciplinary. I know everyone had to leave the engineering building or Huntsman Hall to get here, so we really appreciate that. We had a seminar, our first one, kick off 2 weeks ago, which was really great, and it's an intro to AI. Feel free to look up the notes or the recording on our website. We have a couple more events, 2 more panels, and then 1 Health AI coding workshop for the rest of the semester. And we tried to put together this flow of seminars to match one of our other resources that we're creating this fall called the Health AI Primer. And what that's going to do is sort of get everyone on the same page. It's going to introduce those that are non-technical at a high level to what healthcare AI is. What are the different branches of AI? What is necessary to create a successful health AI solution? And then we pull in a couple case studies of startups and other companies that have been successful at this. And some of them will actually be at our last panel, which is Startup and VC Focus. So definitely stay tuned for all of those things. But right now, we just want to kick it off to our panelists. So.
Okay, so I'm just going to join our panelists here today. So let's just introduce who we're learning with today. Right next to me is Mike Draugelis, who is the Chief Data Scientist at Penn Medicine. And he has been in that position since 2014. Wow. And so we're very privileged to have him here with us. Next to him is Dr. Don Rucker, who leads our country's Office of the National Coordinator for Health IT, ONC, which belongs to the Department of Health and Human Services. He is also a physician by training in emergency medicine, and he has tremendous experience also in the industry. He has been the Chief Medical Officer at Siemens Healthcare USA, and also he has co-developed the world's first Microsoft Windows-based electronic medical record, which is pretty cool. He also holds degrees in MD, MS, and MBA, and some from Stanford, but most notably his MD from Penn Medicine. So welcome back, sir. And next to him, we have Dr. Daniel Herman, who is an MD PhD. He is a practicing physician at our hospital at Penn in pathology and laboratory medicine. He is really at the forefront of developing and implementing computational tools for improving diagnosis and management of patients, especially with cardiovascular events. So, thank you all for joining us today to chat. Without further ado, we'll just kick off into our discussion today.
Okay. Can everybody hear me okay? Yeah, okay, sounds great. So, now, we'd like to get some context of AI. AI has actually been around for decades. And there has recently been a growing excitement around AI, especially in healthcare. And how is discussing AI in healthcare today different relative to previous decades? And what among popular expectations are still largely a hype versus reality?
Yeah, so hopefully you can hear. It's very interesting. So I had, I guess, the pleasure of being at the tail end of the first burst of artificial intelligence. It sort of perked up a little bit in the 60s and 70s, but really there was a lot of interest in the early 1980s. There were a lot of startups and Some of the logic languages had started up. Lisp as a programming language was going pretty well. Xerox PARC. I was lucky enough to be a grad student with a guy named Ted Shortliff out at Stanford, who, as a MD PhD, invented rule-based expert systems. So his thesis was the most cited work in computer science for over a decade. He won the Grace Murray Hopper Award as a young computer scientist for that. So what was interesting in that era, and then maybe a couple of years later when the very first neural nets came, is even as a doc where you're sort of used to complexity, you sort of knew these were very brittle systems that didn't have a lot of compute power. I mean, you just sort of intuited if you looked at what the rules were, what our projects were. I mean, we thought we were clever, but there was really not, one of the stars in the AI startup universe. Basically, the main demo was a rule set that consisted of when to drink red wine versus white wine, right? What kind of be to correlate, not really a deep solution kind of space. And that was the example. What's different now is very interesting. I think what's different now is if you look at the raft of machine learning tools out there, I think they're pretty robust and they end up, at least my sense is, with fairly similar answers often, right? So they're highly dimensional. We have vastly more computing power than we could even dream of. When I was involved and started doing first Windows EMR, we barely had a 1,000K of memory that we had to manage, and we sort of knew where every bit of that was because we had to add memory boards in to do speech recognition. Now, I mean, you have computing power that is phenomenal. The early neural nets had 2 or 3 layers, maybe 3 layers. Now you can scale these things. So I think the excitement of AI is the machine learning techniques are very robust, and some of the newer things called deep learning, I think, are really fueled by a lot of computing. So it's a very different, it's a very exciting space, at least from my point of view.
Okay. Now.
Can I add a couple more things to that?
Yeah, of course.
Yeah, no, I think that's a really great backdrop. And just on the, for the engineers in the room, the other part that's really transformed small groups like myself to be able to deploy these applications at scale in a large health system is this DevOps continuous integration process into the cloud that allows small teams to actually manage, 10, 20, hundreds of applications running. And that's kind of an unsung hero in this AI world.
Now, what kinds of problems now then are appropriate to solve using AI? So, Mike, as Chief Data Scientist at Penn Medicine, could you provide some problem statement examples that you've come across at Penn?
Sure, yeah. Let me give a backdrop on the process a little bit. So what does the Chief Data Scientist do at Penn? What does our department do? And my boss, Dr. Bill Hansen, sitting over here, brought me in 4 years ago to help define, what is AI at Penn and what is my department going to do? And what we focused on from the get-go is providing predictive solutions to help decisions that need to be made at the point of care or at the point of operations, as opposed to hypothesis generation that might be used in research or even just for the business folks to figure out, do we buy this hospital or not? We're really focused on the operations end of it. And so for 4 years, my team has really kind of honed what is this process of understanding what projects are good ones to select, which ones are likely to be achievable to see outcomes for patients in a health system, as opposed to really awesome AI solutions, right? Those kind of can stand on their own and not ever make the journey across into operations. And it's come very simple, a simple statement in operations to say, we want to provide tools that optimize operations, optimize care. So an intervention that's already in play or a business process that's already in play, you understand it well, and you need to optimize a component. So you need to find patients that are best suited for an intervention, or you need to organize people's time better. These are the ways to think about products fueled by AI in healthcare. How do you optimize things? And some kind of categories of problems that we've defined that help our clinical partners and us think about this. what are we optimizing? What is a problem statement? And we kind of put it into 4 areas that we found very helpful. So one is a knowledge gap, right? Like there's 50 patients that you're responsible for. There's a patient that is at great risk of crashing, and you don't know that, right? It might be nice to know that. Another one is, you know, a patient's crashing, but why? You need to make a decision. Should they go to the ICU? Is it a hemorrhage? Is it sepsis? So there's this decision support that you need. The other one is time optimization, right? You're a case manager. Like, it would be wonderful to give everyone a call and wish them a good day. You don't have all the time in the world to do that. Who is best suited for that call, and how do you prioritize that to use the person's time in the best way and to help the folks that are best aligned in that way? And one that kind of arose for us in a surprise is this communication between teams. AI can actually really support that, whereas this collectively viewed as an unbiased risk score, perhaps, that allows a resident working in the hospital's general floor to say, I think this person's at risk of sepsis. I have this score that says that. I'm going to call the ICU and get a bed. Where if you don't have a score that really promotes that conversation, it might be harder to have. So it's kind of this process communication gap. So by listing out these 4 areas, and it's not necessarily exhaustive, but every problem that we come into kind of falls in these 4 areas, it helps the clinical team really assess, is their problem best, is it stated correctly? Are they are they forming the right hypothesis as to what the problem actually is? And then we go into this kind of Mad Lib form of saying, if I knew blank, I would do blank to improve blank. And it sounds really, really simple. But we spend maybe a month or 2 trying to answer that question. So you start to gather the data. If I knew blank, if I knew blank, meaning there's a problem. Like, is that actually a problem? Can we measure that? Can we quantify how many patients with valve disease are going undiagnosed, for example? So if I knew someone had valve disease, then I would do blank. Well, is that action actually captured? Do we know what the clinical team is doing for someone with valve disease? And then finally, you would do all this to see some improvement. Can we capture that? And it aligns this hypothesis of the problem with the intervention that's in play, where you want to optimize that with AI and linking that to outcomes. And that's kind of the maturity that you need in attacking all these problems. And healthcare isn't necessarily unique in having to go through this process. I worked in several other industries that you still have to think this through. So, some typical examples here are, readmission is a big problem. That's kind of like if there's any people that know machine learning, there's a standard data set called the iris data set. You just have to predict what kind of flower is in the data. The equivalent to that in healthcare is like the readmission problem. So who's going to be readmitted? But why do you want to know that? What are you going to do? So it's this general risk score. Are you going to then generally hover around a patient? Are there papers showing that hovering helps? What are the mechanisms in which hovering is going to keep this patient safe? And what outcomes are you actually looking to achieve? So instead, what you might be able to determine is this patient's at risk because they just had surgery and they're at risk for infection, right? So here, that lines up with a particular intervention with a particular type of outcome. So in thinking about how you can test these problem statements with the intervention and the outcome, you can start to really hone in on the problem that you truly want to solve.
So say now we've identified the problem and kind of structured it in a way with a particular intervention that will guide the modeling. What's next? What do we need to actually then create and deploy an intervention into a lot like a sustainable solution? Dr. Herman, curious to hear from you. Could you walk us through the process of developing and deploying an automated diagnostic tool that you have been involved in as a clinical researcher?
Sure, I can talk to that a little bit. Just to step back for a second. So my role here at Penn is in our Department of Pathology and Laboratory Medicine. I'm specifically in the clinical chemistry area. So we do a lot of laboratory testing for specimens from patients, blood specimens, other fluids. And so we report a lot of quantitative data. That data has been quantitative for quite a while. And I was thinking back to what Don was saying before. There's one test that I perform right now that is actually machine learning. It's been around since the 80s, and that's quad screen. We test pregnant women during the second trimester, thinking about their baby's risk for trisomy 21, for trisomy 18 and open neural tube defects. And that's a test that's sort of the only thing that really fits this paradigm of machine learning, where we measure 4 different analytes, and we think about those analytes in a quantitative way compared to a population, and we calculate a risk. Everything else that we do in the laboratory is pretty simplistic, how we compare an individual patient's results to what we think is normal. Thinking about what you're saying about implementing a test, one that I've been focusing a lot on recently started with a clinical use case. The clinical use case that I was interested in is thinking about how do we improve screening for underdiagnosed disease. And one of the underdiagnosed diseases that I was helping care for in the endocrinology laboratory was primary aldosteronism. Primary aldosteronism is one of the most common causes that we can identify for high blood pressure. And we know how to treat it. We know we have specific medications that help manage patients well. Other patients respond to surgery well, so we know how to treat this. But anecdotal evidence suggests that we're not very good at finding these patients. We might find 10% or 5% or even 1% of these patients. And part of that is we don't have great systems that implement guidelines or great systems to make sure that we're thinking about rare cryptic diagnoses like this. And so this was sort of the problem that we identified and we wanted to focus on about a year ago. And we're very much in the development stage of it. But we started trying to pull all the data that we could about our patients from our clinical data repositories. And I've been working with a data scientist on this. And we took a while just trying to understand our information. So we looked at diagnosis code, we looked at laboratory results. We pulled notes and tried to see, could we identify features in those notes that would help us identify these patients. We honed in on saying, well, let's try to match guidelines as best as we can. Guidelines say we should test patients that have treatment-resistant high blood pressure, or high blood pressure and low blood potassium. And so we've been building models for these, and it's been an iterative process. We've been reviewing a lot of patient records, generating gold standard data, this patient does have resistant hypertension or not, and then building some simple machine learning models to identify those patients and training those iteratively, training sets, validation sets. The next steps are really in front of us as to how do we actually implement that. We've started working with the Pathways team. We've identified variability in practice that we think could help us a lot in finding these patients. But the actual implementation is something that we still need to figure out how to do well. I think, Mike, you can speak to a lot better, a lot of the things that you've implemented already.
Yeah, I think a really great place to start in solutions is screening. I think that's a really a great place where you can apply machine learning, where it's taking variables that may not have been considered before to bring them together to come out with a risk that's honed in on that particular patient or the population that the health system is caring for. And in the past year, we really our team has really started to shift towards this screening side that the clinicians are really resonate with. So which patients are high risk for colorectal cancer. People aren't really fond of colonoscopies, so it's hard to get them to go. The guideline right now is if you're 50 or older, get a colonoscopy. But if we have a machine learning model that shows that you're 25 or 50 times more likely to actually come out positive on that, you're more likely then to go and get this diagnostic procedure. And we've kind of seen that, on repeat. I think the key is that the reason that that's so successful is it's something that's already aligned with interventions that are in play. That they're successful, the clinical team buys into that. And when you detect or find someone that's at risk, it can be clinically identified as yes, they are or they are not. There's a simple test to then verify that. So you get a lot of uptake and buy-in right away. I think from, if you're looking to start a startup or some company that's providing these kinds of solutions, the challenge is what is unique about that solution besides this prediction model that's going to really have the clinical team adopt it. And the other side is once you've identified a problem like this, internal data science teams can kind of turn around the model relatively quickly as well. The barrier in generating these models is becoming lower and lower. So the real value is in the general solution. that you might offer the health system and the providers as opposed to just that machine learning model.
Then
Add one thing to that. I guess another interesting example that sort of plays off what Mike just said is the example of blood testing looking for fibrosis in the liver. And so in the early 2000s, there were a handful of scores that were calculated using standard laboratory tests, just taking 4 laboratory tests and dividing them, looking at square roots, and saying this is something that's associated with how much injury, fibrosis there is in someone's liver who has hepatitis C. And fibrosis is the best or one of the best indicators for bad outcomes in cirrhosis and liver failure. These scores, some of which were sort of public and open, some of which were patented and ended up going to a laboratory developed test route. They were available and gave good information, but the actionability of them was not really clear. And then starting the beginning of 2011, we now have these new medications that work really, really well for patients with hepatitis C. And one of the things that was unclear is how do you use limited resources? How do you optimize them? What patients will do best with these medications? And it turned out that we had a big uptick in how many of these tests for fibrosis that we were sending out to reference laboratories, just because these tests were able to give a high positive predictive value. If they had a high score, this patient is very likely to have a lot of fibrosis and will benefit from these medications. And so those tests ended up on insurance providers' checklists as to whether they were going to cover a medication or not. And so that's a good example of we had the knowledge. We were able to calculate these scores for quite a while, but it wasn't until that operational clinical need was in place that those tests became viable and actually were used in a large way.
Yeah, that's good.
when it comes to commercializing a solution that's been worked out, we'll actually have a separate panel upcoming in November that we just focus on commercializing an AI solution in healthcare into a business. But one of the things that we'd like to learn from you is how to think and actually talk about scalability of AI solutions. So, for example, Mike, as a chief data scientist, you and your team probably get approached by vendors quite frequently. What makes an AI solution a harder product for you to buy?
Yeah, and just to note on the term scalability, I think there's a couple of perspectives of it. Mine, being within a health system, I think about how can my health system scale predictive models. So how can our health system manage hundreds of predictive systems? That's kind of how I think about scale. I think from a startup, you're thinking scale, like what's the scale of the market, which I think is the question. Some barriers internally when we're considering these things are, one, how do you validate these models, right? So you can have, say you're a startup and you get this incredible data set from Stanford, you have some kind of agreement to not share that data, and you develop a model and you come to Penn and you say, hey, we've solved, the severe sepsis problem, right? This really great model. I might say, great, can you show me your data? Can you show me how you validated that? And sometimes that's a barrier. I think another barrier is you may solve a very relevant detection or screening problem, but again, how does that fit within the process of the health system? And there's tremendous variability in delivering care. There's tremendous variability in how each EHR is implemented. There's tremendous variability in the data and how it's represented. I think we're going to be able to get to that in a little bit. And so you have to figure out, how does my solution adapt to all this variability in the marketplace? Sometimes there's a blinky light that everybody uses, and you just need a smarter blinky light. I actually don't know what that might be, but maybe in radiology, there's just a process that everyone uses. There's a dominant vendor in the marketplace, and you can kind of attach your product to that. Within the EHR realm, there's some dominant players there, and a lot of vendors come in or startups come in to partner with them as kind of a connection piece, and I've seen companies grow that way. And then there's vendors that kind of start going from health system to health system, but the key is that they're not coming with, here's my AI solution, right? So we had a vendor that actually started up out of Penn that was connecting the right type of care for patients being discharged. So you're being discharged, do you go to a skilled nursing facility? Do you go home with no additional care? Do you go home with home care? Do you stay in the hospital? And they had a solution that was independent of AI. And they worked really hard to create a network of skilled nursing facilities to connect up these groups, health groups with a network of care. And then began to layer in predictive models to try to align risk. And the key was that they were offering a solution and filling a gap in current health systems that aren't connected to these other health entities. And I think those are different approaches that you can take to try to scale.
Just to add to that, yeah, the transferability is a really interesting, really challenging problem. The lab is a good correlate for that because it really depends what you're measuring. We report numbers, and so if we're measuring some fundamental property, like a blood potassium, we could say that a blood potassium on serum, if a patient goes to place A or place B, they're pretty much the same. That might not be exactly true in all scenarios, but we can think about it that way. Whereas if I'm measuring a complex protein, there could be very different results, twofold difference, threefold difference if those tests are not well standardized or harmonized across sites. And so getting back to what is the practice variability, how complex is it underlying data, for a model to be transferable beyond here, we really have to train it beyond here. Yeah. And we have to understand what those potential confounders are and how far away you are from truth.
Yeah. Can I add one more thing to that?
Sure.
That's a really great point, and that's something that we have 6 hospitals in our health system. When we deploy our models, they're different patient populations, and our models perform differently if we're not careful on each of those populations. So if we train a model that works well for our 4, 5, or 6 hospitals, how do we know it's going to work for all hospitals in California, for example?
Yeah, I think it's also important to understand. So we've heard a bit about deep clinical decision models, which has always been, interestingly, one of the sort of areas of hot interest in AI broadly. The rule-based system I talked about that Ted Shortliff built was to diagnose meningitis. That was the first rule-based expert system. It's interesting as students who might be entrepreneurs to try to imagine the dollar flows here and the workflows, right? Because your uptake and success is really going to be if you can replace some part of human labor. Now, if you try to replace Dan's brain as human labor, that's probably a pretty tricky activity, I'm guessing. He's modest, all right? But for example, if you can think about all of the labor in various nursing tasks, the Internet of Things, right? How do you instrument? How do you benefit from instrumentation? If you turn your necks 180 degrees and look over there, you have an incredibly high spending environment that's extraordinarily labor intensive, right? So how can you measure that? And there are all kinds of things. When I was at Ohio State, I tried to do this at Penn, but the phone system had been outsourced, so I couldn't when I was an ER attendant in Presby. Phone calls, right? Phone calls at Ohio State, roughly equivalent size, 130,000 phone calls a day. Half of these are very short. They're median duration of about 27 seconds, right? 27 seconds in a phone call, you're exchanging one fact. If you're exchanging one fact, that's something vastly more interesting to think about automating and putting smarts on than a complicated diagnostic thing I would just throw out for you. So try to get involved in some of the workflows, ask people what their problems are, because that's a great way to move the ball. And there's very, very little workflow automation in healthcare. So it's a massive opportunity. So I would just throw that out because I think those parts are maybe the most interesting things. And some of that you can probably just crib by taking something that's sitting in the ERP world and put it into healthcare and figure out a way to not make yourself totally dependent on the big vendors.
Here.
Okay, so we have talked about problem framing Now let's delve into policy. The Office of National Coordinator for Health IT, which Dr. Rucker leads, and we have the treat today to actually learn directly from you. Where does AI fall into the ONC function? And I'm curious to just really hear, what are the relevant policies that, people in this room who are interested in AI and healthcare should know?
Yeah. So the Office of the National Coordinator is an office that was set up by President Bush in 2004 and is really geared towards encouraging electronic medical records. Under President Obama, 2009, 2010, as part of the stimulus program, there was a $30 billion infusion into electronic medical records through a program called Meaningful Use that led to a lot of electronic medical records. Surprise, surprise. People respond to incentives. And so what we're working on now really are sort of twin problems that sort of touch AI each in a different way. The first, that maybe is not as obvious of a touch, is burden reduction. So these electronic medical records have really become a tool to collect all kinds of data, aka forcing doctors and nurses to enter data into the computer that they weren't really interested in entering. And that starts with the entire way that American office visits are paid for and documented. So there's a lot of work there, and it's interesting thinking about solutions there. One area that in particular is interesting is thinking about a process called prior authorization. So if you want to get an MRI or CAT scan or elective surgery or whatever, the insurers play this big game with the doctors and the patients on who gets what. And that's an area that I think is ripe for better decision-making and automation. So I just want to throw that out. If you want to be in that game, you have to sort of hook up with either the big payers or the pharmacy benefit managers. That's out there. The second big area we're working on is what's called interoperability. I don't actually know if that's a word, but everybody uses it as a word, so I guess we'll call it a word. It is a word. Okay, great to know. So people have thought, I think, maybe, hopefully, well, don't computers talk to each other? Well, computers are rocks, right? They're really dumb. And so any interoperability, you have to program in. It's a lot of work and a lot of work on the business side because the economic interests are often highly aligned to not sharing the information. Nobody will tell you right off they're not going to share the information, but somehow they'll be too busy, it'll be too hard, and they won't do it. Well, Congress, once Congress decides there's a problem, Congress comes up with a solution. And so in December of 2016, Congress passed something called the 21st Century Cures Act. Now, some of you may know that there's a lot of rulemaking in there about the FDA and clinical evidence for drugs. But there's another big set of provisions in there mandating interoperability. And this law, interesting enough, passed almost unanimously. 390 votes in the House, over 90 votes in the Senate, signed by President Obama. And as a political point, I can actually assure you the Trump administration is all about increasing interoperability. We want to do it to increase market competition, low prices in healthcare. That's why we want to do it and give people a good deal in healthcare and transparent access to their lives and their data and their ability to shop for care, none of which really effectively exists today. So the administration has been all over this. Had a meeting last week with Seema Verma, the head of CMS, Chris Liddell, the deputy chief of staff. Jared Kushner has been heavily involved in this. He, by the way, is a very smart guy, just FYI, in case you've been reading the news and thinking he's not, and very, very charitable. So how do we go about doing that? Well, Congress came up with some pretty good ideas on how to do it. And so under cures, there are prohibitions against information blocking. There is something called a trust exchange framework, where these health information exchanges are asked to share data, which they may share locally in various ways, but to make that more national. And finally, for you, the absolute most important provision of cures is something that's absolutely radical in healthcare, which is the concept of an open API, right? So you guys can pick up your smartphone and look through your screens, and you're smart enough to understand almost every single app on your phone uses 1, 2, 3, 4, 5, 6 open APIs, right? Think of something, maybe these days canonical like Uber. Think of, they have credit card, map, traffic, other database APIs. In healthcare, we don't have that. And so part of the rulemaking that ONC is involved in, that will be coming out very soon. Washington, D.C. rulemaking, by the way, is its own little major art form, in case you wonder what all those office buildings are about. When you take the train to D.C., it's about lobbying on rulemaking, just in case you're wondering. So that rule will come out. We think open APIs will be transformative. It'll give you an avenue for entrepreneurship. So as we've talked here about AI, don't forget, we've talked about big data. There is actually very little big data in healthcare if you do anything that is delivery system related that goes beyond one delivery system. If you're within a delivery system, if you're in the Penn system, you're in the Jeff system, you can get the data there with, IRB internal review. But if you're a United Healthcare or Highmark or Cigna, Aetna, Anthem, if they haven't merged yet, very, very hard to get data. The vendors and providers somehow end up charging to get electronic access, unattended electronic access to an electronic record on somebody whose insurance you're covering. That may be $5 a pop. So all the big payers are working to actually build out API standards that do not just individuals, but entire populations of care. So I would say for this panel, as you think about policy, think about what data do you have available, where you're going to get it, how are you going to get it, what the implication is under HIPAA, the privacy law for getting it, and you're going to have to think a bit about the economic interests, because you can have the greatest algorithms, but if you don't have the data, there is no AI. And much of what we want to do as a country is really predicated on these this broader access to data. Obviously for ONC, for the federal government, it's a great challenge to figure out how to do this with the best of privacy and security. So that's the kind of thing that we balance on your behalf.
Just want to add one other thing, just from internal health system. Talking to my counterparts at like institutions, there's a maturity coming around these applications, vendors coming in with them. Maybe 5 years ago, there'd be a hot debate by the lawyers between a health system and the vendor about who owns the data, and if I give you my data, do you pay me back, and how does that all work? And what's evolving now, just taking an informal survey with my counterparts, is there's a recognition that if you're buying a product that has an application that uses AI, they need data to make sure that AI continues to perform well. And there's just a satisfaction that the value being provided is the value through the application measured at the bottom line. And there's not quite this debate anymore about, well, okay, you need our data to keep the model working well. How are you going to compensate us for the data we're giving you because it's giving you value to the algorithm? That conversation really isn't happening anymore. It's just this acknowledgement of how these applications actually work and how you keep them moving.
So one little hint for the would-be entrepreneurs. If your business plan revolves around selling data, be very wary. So when I was CMO at Siemens, we got a lot of business plans. And the most highly predictive biomarker, I'm using the term loosely, Dan, of business failure was a heavy reliance on, quote, selling the data. How the data got in, nobody knew, what they were going to do with it, unclear, who they were going to sell this to, unclear, but somehow we were going to sell the data. So if that's your plan, I would just put your thinking cap on one more time and make sure you got it nailed.
With that, let's open up to questions with the audience. So, any questions? Yes.
How much of your AI work is focused on creating knowledge as opposed to automating or expediting existing best practices?
That's a good question. I sort of do some things that I think of as more clinical operational and some things that are more medium term in research. So on the clinical side, we're definitely putting our data together and thinking about operational goals, thinking about some things that are clinical decision support, like how do we help clinicians order the right tests and interpret those tests, and our operations, our turnaround times, how quickly can we get results back, and really focusing on that. Those are the use cases that make the most sense for us in the short term. Research and intellectually, I'm much more interested in identifying care gaps. Those care gaps, the screening for underdiagnosed disease, I think there are a lot of those that as we organize our data better, we can get at with simple heuristics, and longer term do even better and better with more sophisticated AI. So I like thinking about both of them. Shorter term, it's the easier things, the easier models, and the more operational goals that I think are going to have the quickest yield.
Yeah. Oh, thanks. Yeah, and on the operations side within Penn, we think of ourselves as R&D. Traditionally, we're trying to apply something that might be done for the first time, but the technology itself isn't new, wholly research. And so we're doing that to manage our risk. And we do have publications that come out of our work, but it's more on the delivery of care as opposed to here's this new methodology in creating an algorithm. At Penn, we have an Institute for Bioinformatics led by Dr. Jason Moore that they really push forward, some new approaches in applying AI and data science to medical data.
When it comes to things like you mentioned diagnostics and screening for new kind of diseases, when it comes to using AI algorithms like neural networks that are just sort of black box approaches, how do you reconcile the need to be able to peek underneath and see what's actually going on with the results that you're getting? Will something like that ever be FDA cleared? How does that look going forward?
I think it's an active area of research. I mean, I know of at least one startup that's focused heavily, a company called Kyndi, K-Y-N-D-I, on explanation. I think it's incumbent, if you want to have real end user success on machine learning things, that you somehow tie it to some form of explanation. I mean, that's just, that type of accountability is the way the world works. And I think it's a big business opportunity as well.
Yeah, there are a lot of good challenges in there. If you think about the bigger picture, like FDA draft guidance, there's sort of separation between clinical decision supports and things that you can't understand. From my perspective as a laboratory director, I really want to bring in things into my lab or send tests out that I can understand. And I could do that for a black box, but it's a lot harder to be comfortable that it's going to work in my population unless you have huge studies. And so I'm much more interested in the idea of something that's explainable. And on the research side, I'm doing some work with collaborators like Jason Moore that are thinking about flexible models that can actually be explainable. And it's really a trade-off. And there is a lot of method development work being done there. I think we'll have some models that have to be a little bit harder to understand, but the validation and the monitoring will be all that more important for those kind of models.
I think it's also important to put a box around what we mean by understandable and trustworthy. It's really important to have that transparency in a model for safety and to gain trust behind it. But I think it's a mistake to say, we're going to put this prediction out there and we're going to show clinicians what the model thinks is important. That's a misunderstanding of the process of machine learning. These things are not causal, right? They're correlated. I think it's different if you're a researcher using machine learning to kind of generate hypotheses. The way we use these things is understand if there's model drift, if the model needs to be retrained. And I think the transparency allows you to understand you have some kind of ethical bias perhaps in the model that you can explore. But you have to treat understandability very carefully in these models. It's not like you're building an algorithm that's going to get you to Mars based on principled physics, right? These are statistical correlations.
Right, well, thank you for joining us. I worked at a large tech company before coming here, and it's always been amazing to me how much search data we have on things like browsing behaviors and actual keywords that people put in. And it's pretty underutilized in the healthcare space. How do you think we can better tie that kind of data into predictive healthcare, particularly in things like mental health?
Yeah. Go ahead.
Yeah. Obviously, it's hard, right? And mental health is a particularly thorny area, even at its most basic level. I mean, I spend a fair amount of my day trying to even put some policies in place so that we even know where patients with behavioral health issues are going, right? We don't really know where the people are, where they've been, where they go. If you go to any ER, I mean, you just don't know the trajectory of these folks. That's even before you get to treating them or anything else. So I think there's some massive areas. A lot of that will come down, I think, to some interesting questions, because that's really research is what you're asking at this stage, on how good we get at de-identification, right? Because I think the challenge is, for identified data, we have some pretty straightforward ways of dealing with it. The problem is it's getting harder and harder to de-identify data because we're getting better at re-identifying data. And so I think those are related problems because that's what you need. I don't know what you do at Penn on that.
Yeah, no, it's a really important problem. There's a ton of data out there, and I agree. There are population health questions that we can be doing a lot better at. There are several investigators at Penn that work on these kind of questions, like Graciela Gonzalez, thinking about NLP and applying it to different data sources that are out there. The flip side is also true. De-identification is really important for developing these algorithms, but if we want to tie it in to the health system, we have to figure out how to identify it and link people's information using APIs in a secure and accurate way.
One other thing that is sort of currently in play in Congress that didn't get put into the opioid bill that's making its way through is there's actually a separate prohibition against certain classes of addictive behavior in transmitting that, something called 42 CFR Part 2. You don't need to know the exact legal things for any law students here. But that policy makes it extremely difficult as a practical matter to share even clinical data that we're sharing on other patients. So there's inadvertent discrimination against behavioral health patients through this policy, which was meant to protect them.
Yeah, this is something that we've explored over the past 3 or so years at Penn. There's actually a Center for Digital Health run by Dr. Merchant doing really great work, trying to understand the link between the digital signal and social media and patients' clinical data, and has some really great work where she's gotten thousands of patients to agree to give all their Facebook data to the team to line those things up, and they publish. So I would recommend taking a look at that. I think one thing that's interesting is I don't know if anyone has read the book Weapons of Math Destruction. There's this thought that other kinds of data could give us insight into the mechanisms of health and illness, like credit scores. Why is that? Right? Someone has a bad credit score. Maybe that's helpful in predicting readmission. What's the mechanism there? Why would that be useful? What you open yourself up to is putting in unintended bias and consequences to people in your model, unless you really have a hypothesis to what that mechanism is. If you're just driving to the best predictive model, that's not necessarily what's best for the health system or the patient. The other thing is data privacy works interestingly the other way too. We've talked to a few companies that provide search for everybody, and they were much more protective of their data than we were of ours. Which was interesting because we said, well, why don't you give us de-identified data and we'll just explore it to just try to understand what some key questions that we could ask of this data. No, we can't do that. It's not even a conceivable thing to do. So I think it goes both ways to explore that and trying to bridge that gap. But I think you have to, there's certainly some value there, but I think approaching it really respectfully, asking these careful questions is important.
Yes, back there.
Commented on it just briefly. Can you sort of explain the regulatory environment in which you work in? What exactly is the difference between clinical decision support versus software as a medical device that FDA regulates? At what point do these things need to be approved?
Could you summarize the question?
So the question was a perennial question at the FDA, which is what is, to sort of abstract it, what is the nature of, should be the nature of FDA regulation of software, right? So when is it a medical device? When is it decision support by the clinician, I believe? So historically, and this question has been in play for 20 odd years. I remember, in fact, early discussions about this when I was a grad student, which was a long time ago. For the longest time, FDA just simply punted on it, right? It was something they had said they were going to address, but they just never got around to addressing it, right? Never got around for like decades at a time because it's sort of hard. And up until very recently, the de facto policy was that if there is a clinician intervention between the software and the patient, it's not regulated. So decision support, to your question, would not be regulated. On the other hand, the class example was always given, if there's an automated, let's say a ventilator on an anesthesia machine or just a ventilator, that would be regulated because that's unintended use. More and more software, of course, is pervading everything. So Congress took a stab at it and actually essentially carved out in Cures, I believe it was the Cures, a exemption for apps and basically told the FDA, go away. You don't regulate this. What the FDA has done on the things that are more medical, if you will, is they've come up with a program on sort of certified software developers, right? So this is, I believe, what Apple used for the EKG monitoring on the Apple Watch that they just announced. So where FDA is using sort of like an ISO type of standards process to certify development, and this is really being tested still. We have a couple small companies, about a dozen, some small, some large, to see how this goes. So that is the current FDA approach on that. Now, this is all subject to elections. So for those of you who read Politico this morning, a number of Democrats in the House, I forget the main one, but basically said, we need more regulation. So they basically send a letter to Scott Gottlieb, tell us what you're doing. We think all these things should be regulated. We think this certified developer program is not adequate and is a danger to the public, so we would like more regulations. So I think these things, like many things, these things have an ebb and a flow. I believe this is very, very, very hard to do without just stopping progress. So my guess is these policies will actually continue, frankly, independent of party, but that's just a guess.
Yeah, and I think and so being internal to Penn, we look at our projects as quality improvement, clinical decision support. So we manage it that way. What I think is interesting though is deploying artificial intelligence, deploying machine learning is a really complex process. It has many traps along the way. We do everything perfectly at Penn, so there's no problems here. But I've seen a lot of models developed wrong. And not because the data scientist was wrong-minded, but because they made a mistake. Example, you can develop a model to detect events where you report, 97% accuracy, and you basically mixed your test and trained population inappropriately. I've seen that many, many, many times. And so you could report a certain accuracy with an algorithm, develop an intervention based on its assumed accuracy, deploy the system, and never realize with unintended consequences. I think there's inspections of different departments, pathology, that are done to certify things are done properly and safely. I would welcome that kind of conversation for predictive models within health systems. I think there's a lot of things that could be targeted and kept safe.
And I think it also behooves you to just work through it in your brain. Does this make sense? Right? You're going to hear so much stuff in your careers. Just ask yourself, does this make sense? And the less it makes sense, I mean, the more just ask yourself, how did this happen? Look for other proof statements. I mean, you guys are smart. Be smart about this, right? Because you're going to hear all kinds of stuff, and you won't be able to evaluate all of it. So just be real clever about it and try to look for other correlations.
Yeah, the rules are definitely in flux. If you think about one example in that space, coronary disease polygenic risk scores. There are very interesting publications recently, and we're talking about, can we use this clinically? There you're looking at genome-wide markers, and you would talk about risk stratification of a patient. It's clinical decision support, but it's not something that the clinician can replicate. They can't think about those millions and millions of markers. So in my reading of draft guidances, that would not be called clinical decision support because it's really complex and the physician cannot replicate the logic. Other details are just where tests are performed. In the clinical laboratory space, something like Oncotype DX is performed at a single place. And so it is, it's under CLIA 88 regulation. And so it's up to that laboratory and inspections by peer laboratories to make sure things are done well. FDA is not currently regulating that. Whereas if you're providing something that you're going to sell and it's going to come to my laboratory and someone else's laboratory, and we're going to perform it, that by definition is falling within FDA clearance and oversight. So there is a lot of common sense and a lot of complexity that's not fully fleshed out. And so thinking about that conservatively, I think, is a good approach to it.
For the interest of time, we will have to close our panel soon. Are there any last minute kind of remarks that you would like to share with the audience here and live?
Yeah, I guess just some thoughts on where data science is going that I think is really exciting. I think becoming closer integrated with the clinical workflow, trying to figure out how we can help this hypothesis generation space in clinical action is a big area of research, one that can really transform the way that AI is really helping healthcare in the next 2 to 3 years.
I would recommend to folks, any of you probably have already done this, but for folks who haven't, take a programming class. Try to learn what a data structure is. Try to understand a basic algorithm, right? Understand the differences between a couple sorting algorithms. Because the ability to think precisely about these things is going to be a super valuable thing for you throughout your careers. It really is going to it's going to allow you to add a lot of value in a lot of places in your career. I know sometimes, programming class is daunting, but I would just ask yourself or buy a book on algorithms, just get a flavor of it, buy a book on data structures, and just get a little bit of a flavor of what the absolute engine that's fueling all of this is all about.
Yeah, it's definitely true that it takes a lot of expertise to be able to execute on these. And the more that you can understand, I think the better you'll be able to think about those problems. I think there's a lot of opportunity in this space as we improve methods and we get better and better access to larger and larger data. I think the key is focusing on the use case, whether it be an operational efficiency use case with a clear goal or a clinical care gap or an improvement in care. What is that question that you want to focus on, and what's the action that you can tie your method to? I would start there with anything.
So as a next step after this conversation, next week we'll actually have a machine learning coding workshop where the goal wouldn't actually be to learn exactly how to code, but you'll get a sense of it. So for those who attend, we'll actually have a specific clinical question, problem statement example, and an algorithm, and also an output, and how it looks like, and how do we actually interpret it, and how it might actually be translated to impact care. This was fantastic. Thank you guys, and thank you all for coming.
So the primary algo stuff, that's great, yeah. You know, some of this, did you ever have a book called Beyond Normality?